use your translate. You say? Okay. You did not?
The mic
Yeah.
is not connected to any speaker.
Okay. It's not connected.
Sur le micro, et pour le peuple online, pour l'interprétation. You will not hear yourself in the room.
Okay.
It's for people online so that the interpretation can work.
Okay.
Everyone
Maintenant,
should
for person who is here,
ils ont attendre de parler sur la voix d'une personne qui parle.
ils vont?
They will hear you through your voice.
Ok, mais pour l'interprétation,
Et-
comme moi je vais parler en français.
Si tu veux parler en français, c'est totalement OK.
Oui.
Il y a l'interprétation qui va répondre.
Qui va répondre. Est-ce pour eux maintenant qui sont là?
Ils ont écouté aussi.
Ok,
Ils vont choisir les langues.
ok,
OK.
d'accord. Thank you. He says it, this smartphone with 4 person with online. Okay. Now you have to use your utiliser vos écouteurs pour pouvoir me suivre. Voilà. Donc, je vous remercie pour votre attention. Nous avons 3 présentations. La première présentation, c'est The Hidden Tool of Killer Absenteeism, exploring its impact on health workers and emotional well-being. Presentation by Onochi Edgy. He's here, okay. The second presentation will be the presentation of Joseph Wadiko, okay, and his work is entitled of health worker employment among countries with critical health workers shortage. And the last presentation will be done by Syed Isiaka, and this title is a situational analysis of human resource for health at the primary health care facilities in Nigeria, examining the stakeholder. Okay.
Ces 3 présentations, moi je suis là.
Bon, ce que j'ai reçu. Donc, vous venez d'envoyer. Hmm?
J'ai envoyé depuis ancien. C'est lui qui m'a donné les présentations.
I had two so far, but the fourth. He will be presenting after. Yeah. Yeah.
Okay. What is his name? In order to not waste time, we invite Mr. Onochi Ed, to start your presentation. Je rappelle que chacun aura 10 minutes de présentation. Voilà.
Thank you very much, everybody. Good morning. Please hope I'm audible enough. Good morning, everybody. Hope you enjoyed the gala night yesterday. I'm happy to see you guys here. I'm sure most of us, I'm sure most of us are still sleeping from a lot of enjoyment. That's fine. So my name is Onochie Eze. I'm from the Health Policy Research Group, Nigeria. I would like to start with the theme of this conference, that's building resilient and strong African health systems. So we cannot talk about building resilient and strong African health system without the key component, which is the human resource for health, the health workforce. And I would like to say that the health workforce is like the operating system. So without the health workforce, we cannot do much. All right, so sorry. So a lot of research has gone into the health workforce, those based on their welfare, everything regarding efficiency and of the health workforce, right? So what we're trying to talk about now is based on corruption. Now, this study, The Hidden Toll of Colleague Absenteeism, exploring its impact on health workforce and emotional well-being. It's a fragment of a broader study that our research group has been doing for over 5 years now with the SOAS Anti-Corruption Evidence Consortium. So we've talked about, we've ranked absenteeism based on studies as the #1 corruption in the healthcare system. So what is absenteeism? Absenteeism is a habitual or frequent, absence of a worker, a health worker in this context, to work. And how is absenteeism corruption? A lot of people will think. Imagine being paid for, if you're being paid for something and you do not, come and deliver on the service you're paid for, then I think that's fraud. We may not see it in that light, but if you're being paid for something, then you're expected to deliver on what you're being paid for. So let's delve right in. So here's the background. Absenteeism is a significant issue in a healthcare setting in Nigeria. The studies have shown high rates of absenteeism in primary healthcare centers, right? So, another study, has shown that 242 health workers, the study that was done on 242 health workers found that 110 of them, at least one spell of each, had one spell of absenteeism in a year, while qualitative research finds it to be pervasive. Okay, so the impact, absenteeism not only affects patient care and healthcare outcome, but also creates heavier workload for the remaining staff. Okay, so what's our objective, in this study? Our objective is to ascertain the relationship between colleague absenteeism and health worker burnout. Also, the second objective is to examine the emotional toll of individuals covering absent colleagues. Okay. Our methods. So this research was done in Enugu State, was done in 5 purposefully selected LGAs, covering both the urban and rural context. And they were done specifically, but marked LGAs were marked for high absenteeism rates. So the participants, like I said, it's a broader study, but these participants that were part of it were 12 female workers that were purposefully selected in 12 PHCs based on the experience and knowledge of colleague absenteeism and also their willingness to cooperate in the study. So our analysis, so we did a thematic analysis using the NVivo software, and the code book was developed by 3 researchers, in order to validate the analysis. Okay. So what were our findings? This is moving too fast. What were our findings, right? So we found out that there was increased workload and stress. Health workers frequently mentioned the absenteeism led them to increase workload, and with those present having to do more work. Let's say you have a shift of about say 3 hours, and someone is meant to come and take over from you, and the person doesn't show up. You're not going to just leave the patient there. You'll be forced to somehow extend your own shift. All right, the second thematic analysis in our findings was emotional responses to absenteeism. Health workers also felt, a high level of frustration and disappointment when their colleagues were absent. So the third one, which I find, to be the most interesting, is burnout and absenteeism cycle. A cycle was observed where, based on the fact that you're coming to work and you're being stretched more than you should, you're doing more work, there's increased workload, you're burning out, there's a high chances of you not coming to work the next day. You get frustrated. So it gets us into a vicious absenteeism cycle. All right, we're going to see, these are a few excerpts from the field. Some of our, some people mentioned, okay, this one said, at times, maybe when the person didn't explain the reason for being absent, it makes me feel bad. When you finish your shift, maybe you have other things to attend to, you get disappointed by your colleague not being on duty when they're supposed to be. Another one with the header of a bulky work, our respondent said that when they're not at work or when they are at duty post, we have a bulky work, and that is that our work, we have too much work to do, right? So lack of support, because we are supposed to have division of labor, but I'm taking care of all of them. So I'm not happy when we don't have enough workers at work, at morning duty or afternoon duty or night duty. So these are a few excerpts from the field. What are the implications of this colleague absenteeism? And how are we going to address this root cause? First of all, we should invest, what part of the interventions we should aim at is investing in the well-being of health workers by providing some sort of emotional, let's say mental health support, evaluation, to help manage the stress and no matter how small. I know most of the time these things may seem like so much interventions, but no matter how small, even just be a bit more intentional about it, have it at the back of our mind. So the second one is to promote workplace culture. Creative a supportive environment. So if we create a supportive environment for health workers, right, and there's a level of cohesion, if tomorrow you want, as a health worker, if I know that I'm going to, my being absent for no, just cause is going to lead, my colleague to be, depressed, to be sad, that level of collaboration and cohesion is going to make it, is going to reduce my chances of wanting to be absent. So these are like ways to addressing it. Then another one is strengthening the monitoring and accountability mechanisms, right? So we can have a vertical mechanism whereby, we're having we're ensuring that we are, supervising, people at the top, make sure that we're supervising the health workers, and make sure that we put these mechanisms in place, to monitor them. Then we also have a horizontal mechanism, maybe some sort of say citizens accountability mechanism, whereby those living around the place should, once in a while, they should create a mechanism where they can come in, check, and have a way of reporting back to the system. You understand? I think for me, I think that citizens accountability mechanism is like going to be the most effective. All right. Okay, my conclusion, call for action. So the study highlights the need for healthcare organizations to address this hidden tool of absenteeism by implementing targeted interventions to support workforce and organizations and create a sustainable, supportive healthcare system. What are the next steps moving forward? I know we've done a whole lot of research, on absenteeism, and but I think there's a whole lot more to be done. We have to get to understand, okay, what exactly is causing this absenteeism, right? And how are we going to tailor, after we've gotten, after we've had as much research as possible, how are we going to tailor these interventions to address this root cause? And by doing all of that and ensuring an efficient and effective healthcare system, thank you very much.
Thank you very much, Mr. Onochie, for respecting the temps. Vous avez bien respecté le temps, donc 10 minutes net. Donc, nous passons rapidement à la deuxième présentation pour appeler Dr. Joseph.
Good morning. My name is Joseph Mwaduko. I'm a physician and health economist at the University of Pennsylvania. And I will be presenting today on health workforce unemployment among countries with critical health worker shortages. This is done in conjunction, thank you, conjunction with soon to be Dr. Dua and Liza Inyaurita from MRAF. So our point of departure is that while, of course, there are a number of countries with health workforce shortages, we've realized over the past decade that this has been increasingly superimposed on increasing health workforce unemployment. A survey, at least a study of 10 labor market surveys by the WHO has indicated that 24% of health workers are believed to be unemployed in sub-Saharan Africa. There are a number of specific case studies of countries and their experience with health workforce unemployment and the way that they've managed it and the way that individuals have confronted it. But there are very few case reviews of those analyses, particularly focusing on countries on the safeguard countries list, the red list. And that's the gap we want to fill, to both collate the quantitative estimates that have been done, including those that have been done in the effort led by the WHO, as well as collate the qualitative data from these countries as well. So this is a mixed methods document review of labor market analyses, peer-reviewed literature, published reports in the gray literature, and news articles related to unemployment for each of the individual safeguard countries. What we basically did is go to Google and PubMed and look up the words health worker unemployment, physician unemployment, nurse unemployment, and midwife unemployment for each of the 55 safeguard countries. And we did a search in English, French, Spanish, and Portuguese, representing the lingua franca of each of the individual countries. The distinguishing characteristics of all the literature that we pulled is that each of the sources have at least one quantifiable estimate of the magnitude of health workforce unemployment. That being said, in each of those sources, we also analyze the qualitative data to understand the qualitative experience of countries dealing with health workforce unemployment as well. A number of estimates we treated as partially identified, and we provided Mansky bounds for those estimates as well. So we were able to find 91 unemployment estimates for health workforce across 32 of the 55 countries on the safeguard list. We used 74 of those estimates in the study. This accounts for about 28 countries in Africa. This goes back to 2004, just to give a sense of how far back this problem has emerged. But most of the estimates are from between 2014 and 2024. The majority of these estimates come from health labor market analyses. 20% come from peer literature and reports, and 35% come from news articles citing government officials or unions or professional organizations. We found on average that 27% of physicians in reporting countries and 34% of nurses and midwives were unemployed. This is in line with the WHO's own estimates on health workforce unemployment. What we have to add here is that 56% of graduates from health education schools enter the labor market and remain unemployed as well. Look at the map here. The countries in, it should be gray, but light blue are safeguard countries, and the countries in darker shades of blue are the reporting countries. You can find that the countries in the Francophone regions of Africa are the countries that are most likely to report and the countries that are most likely to be affected. But particularly for graduates, you can see that this affects a lot of countries throughout sub-Saharan Africa. This also, is it's a profound problem that crosses health systems, crosses language barriers as well. The only two countries that we found that did not have health workforce unemployment levels above 5% were Zimbabwe and Rwanda. Just to put a finer point on the issue of graduation and graduating into saturated labor markets, we found that there are a number of countries that have struggled to absorb new graduates into the health workforce. So for example, Zambia, between 2016 and 2021, has only been able to expand to account for 50% of the new entrants into the nurse labor market. For Ghana, that number is 0. Between 2019 and 2022, there are currently 68,000 unemployed nurses in Ghana at this moment. We didn't find much data with regards to gender. We only found one gender-specific estimate that 35% of women doctors were unemployed in Pakistan. I'm going to structure the rest of my talk across 4 specific themes that kind of describe what we found in our case reviews. The first is education-driven oversupply. So, there's a lot that has been said, including by Dr. Assoumani, regarding the coordination, the poor coordination between private sector training educations and the public sector, particularly since private sector educations are driven by tuition revenue, tuition incentives, and have been unable to stop admitting classes even when the labor market is saturated. This is also the case in Cameroon. Cameroon gave subsidies to the education sector in the year, starting from the year 2000. And ever since then, they've expanded their nursing education market, and they have 69 nursing schools, although 75% of nursing graduates are unemployed. There also can be this coordination in the public sector as well. So in Guinea-Bissau, the public nursing school, the École Nationale des Sodes, opened a new admissions in 2017, despite there being labor market saturation. In 2019, the actual Ministry of Health opened a round of competitive exams in Gabon for 499 new midwifery students, despite there being 100 unemployed midwives in the country. So once momentum begins on education in admissions, it's hard to stop. There's also, of course, a paradox, as many of you know, with high vacancies despite unemployment. I'm going to focus a bit more on the geographic component, particularly since these vacancies are large in rural areas. As often assumed and many times true that these vacancies remain unfilled because some graduates cannot or are not willing to move to rural sectors to find unemployment. What we also found is that one of the big barriers is that these vacancies are unfunded or not funded in adequate time. So in Malawi, there's a 70% absorption rate for nurses and midwives, despite there being a 54% vacancy rate, but that's because the government has been unable to fund the vacancies within the rural sector in time. Ethiopia indicated a similar phenomenon in 2019. A survey of 3,300 nurses and midwives who were unemployed in Nigeria indicated that 95% of them were willing to work in rural settings if given the opportunity. So there is some demand to work in rural settings if they are appropriately financed. Bangladesh represents a very different phenomenon. For several years, there were more doctors than there were nurses in Bangladesh. And because of that, the private sector began to generate an entirely new form of health workers that they called ward boys, that were not trained in nursing schools, but provided the responsibilities and services that nurses provided. The problem is that by the time that the nursing education capacity in the country had expanded, nurses unfortunately graduated into a labor market that was saturated both in the public side and the private side by these ward boys, and were unable to find employment within the country. There's not much more I can say about informal labor than has been said yesterday. There was an incredible session done talking about how individuals who cannot find employment are often relegated into second-tier employment or unsalaried employment within the public sector. Right after the Ebola pandemic, it was found that between 40 and 50% of health workers in countries that were affected by the pandemic were unsalaried. In Cameroon, the graduate side I spoke about earlier, oftentimes they're called backpack nurses, and they would go between houses and provide services there. In Sierra Leone, we heard a lot about it. We were supposed to hear about it today, but a lot about it yesterday as well. They work parallel to the public sector, and they might bill individuals for additional services, despite them being in receiving services by the public sector that should not involve any additional out-of-pocket costs. Guinea-Bissau, physicians are actually affected as well. They were given an agreement to serve 5 years in the periphery of the country, and in return, they would be integrated on the payroll in the public sector. But across all these settings, there's a high amount of vulnerability. And in many cases, the promises that are made to be integrated on the payroll eventually are not kept in a reasonable amount of time. The final category is migration. So Saudi Arabia has become a common destination for unemployed nurses. Tanzania, Nepal, and Bangladesh have all signed bilateral migration agreements with Saudi Arabia to send nurses overseas. The Malawi Nurses Union tried to do a similar thing in 2023, but was blocked by the Malawi government on the grounds that the Nurses Union didn't have the authority to negotiate with a foreign power. In 2023, also, Uganda announced a plan to send its nurses to Germany and the UK, but there's significant pushback because there are still significant shortages in these countries. But the interest remains to follow through with that. The other half of this is that at the same time that there is unemployment in these sectors, some of these countries have immigrant physicians, immigrant physicians that are filling these posts, filling these vacancies, leading to a lot of tensions with physicians that are unemployed. So this was the case with Angola, with Cuban physicians, Chad, and Mauritania. So in summary, health workforce unemployment is a pervasive, although it's an unevenly monitored problem. We need regular, detailed monitoring, particularly across gender and by cohorts, graduating cohorts. There's a need for governments to urgently open the budget space for health workforce allotments, as well as to better coordinate with training institutions. And there's a need to contextualize migration in the setting of unemployment, because this is going to continue to happen, continue to come up to be a crisis unless the above issues are fixed. And there's welfare losses for the health workforce that are unemployed. Although, at the same time, there's a tension that if someone were to leave the country, they might not return. And so this is a tension that governments will have to confront over time. In closing, I just want to discuss a couple of pressures that are on the horizon. The first is inflation. There's been a lot of inflationary pressure, and there have been minimum wage increases in a number of countries, such as Nigeria, in the context of union pressure. But that will place more pressure on public sector wage bills and can unintentionally lead to more unemployment in the future. The second is the end of US government funding. Our analysis found that PEPFAR alone funded the salaries of about 39,000 frontline providers across the safeguard countries. And so this is likely to have distortionary effects in the future as well. The final thing I think that is important to keep in mind is that over the past decade, the International Monetary Fund has been putting more conditionalities on its loans, including on the amount spent on public sector wages. Between 2016 and 2021, 13 safeguard countries have been requested to actually decrease the public sector wage bills by amounts between 0.2 and 11%. This doesn't necessarily include health workforce, but it sometimes might. And so this is something that we have to remain vigilant about as we continue to fix this problem. Thank you, that's all.
Thank you very much, Dr. Joseph. Nous passons à la présentation suivante, la troisième. Je précise qu'on a une quatrième présentation qui sera faite par Doua Rufai. Donc, nous appelons Dr. Isiaka pour votre présentation. Ten minutes.
Thank you. All right. Good morning, everyone. I think my presentation is built on most of the conversation we've been having over the week concerning the challenges that are affecting the health system in Nigeria. And a specific focus today will be on this gap analysis around human resource for health challenges. So my topic is a situation analysis of human resource for health at Premier Healthcare facilities. So here we try to meet up with stakeholders across 5 states in Nigeria. And the idea was to get their perspective on what could be the issues concerning human resource for health. And to get this, we used the framework, which you would see along the line. So basically, my presentation is just to give you nuances of what the challenges are. Okay, yeah, we would all agree that primary health care is the cornerstone of health system in any country. And also it's very crucial to a robust healthcare system. Despite that, one of the key things required in primary healthcare system is a good, adequate human resource for health. But in Nigeria, we have that gap. So it's a very major gap in the health system in Nigeria, particularly the first point of health system contact in Nigeria, which is the primary healthcare services. So the primary healthcare system in Nigeria is mainly in 3 parts. There's the health clinic, the health post, and the health centers. So we use community health workers at the health post, but use professionals starting from the health clinics up to the health centers. So we have the division of putting community health workers and other professional health workers like doctors, nurses at the health post, at the health clinics and health centers. However, concerns remain about the inadequacies of providing care at the primary healthcare centers. For instance, studies in Nigeria have revealed that high rate of maternal and child mortality is associated with the quality, size, and distribution of human resource for health. So in Nigeria particularly, maternal and child mortality is at 1,047 per 100,000 beds and 63 per 100,000 live pets, respectively. This was from the MixNIX data in Nigeria. So despite several efforts that have been put in place by the Nigerian government to address the skilled birth attendant gap, we still have issues concerning this. And so the idea of this paper or this presentation is just to understand the various challenges affecting human resource for health across thematic areas. Now, to do this, this is like a offspring of a major project. And from that project, the project was funded by Bill and Melinda Gates Foundation. And the idea of the project is to understand the core issues affecting human resource for health. A second part of this was presented in MH1 yesterday. But mainly what we then did was to generate a composite index. But to do the composite index, we had to then use indicators, for instance, trying to measure the per capita income of primary healthcare facilities, the size distribution of primary healthcare facilities, size distribution of health workers in primary healthcare facilities. And so based on that, we use the Human Resource for Health Action Framework by WHO to then come up with indicators across different thematic areas. I'll show you the thematic areas along the line. So based on that, we categorized the 36 plus 1 states in Nigeria into 5 categories. So upon generating the composite index, we divided into 5 quantiles, of course, and based on that, the quantiles, we now give them the levels. And after that, we selected 5 states, 1 representing each of the category, to conduct interviews. These interviews were done with high-level health administrators within the state. So many of whom are like directors, like coordinators and things like that. So the interview were then transcribed and coded using Deduce. So now I'll start talking about my findings. So before I came up with this, I thought about what was the best way of trying to put my findings out, because the idea is I want to communicate the nuances of these challenges and not just talking about what the challenges are in summary. And so summarily, we have the leadership and governance thematic area, the financing, the human resource human resource for health information system, the production and in-service training thematic area, and the midwives, the size and distribution. So each of these thematic areas were then used to generate questions to interact with the stakeholders who were involved or who were interviewed. And from the first category, the state that was representing the first category, their major issue with leadership and governance is lack of, I would say, first of all, almost all the states we had the interviews had expired or no, what's it called? No plan, human resource for health policy and strategic plan particularly. So for this state, the interviewee was like mentioned that 5 years ago that they had HRH policy plan about 5 years ago, but currently don't have one. For their financing, although they do have an operational plan and they do budgeting for their health workforce, but there is no specific finance for human resource for health, and which is actually also a major issue. About the information system, the state does not have any electronic information system, but only uses the manual ledger that exists. Then for the production and in-service training, so they do have a number of large students, which I think is tied to the presentation from him and also from me. So they do have a number of large students that they try to produce, but don't have the opportunity to get them employed because, of course, there's no budget for, recruiting new staff. And many a times, some states are dependent on programs that come in to programs that are being implemented in the states. And of course, they then bring them in and fund them through that. So for their midwife size and distribution, so this is skewed because they mostly have, like this person said, currently we do not have up to the minimum standard package requirement. So as I mentioned earlier, we have 3 categories of primary healthcare services in Nigeria, and this is often based on the standard minimum package of the primary healthcare service. So the interviewee emphasized that currently we do not have up to minimum standard package requirement, but based on what we have now, there are 352 nurses and midwives, while we have about 800 CHUs at the moment. So this is Q in the sense that if you calculate in that particular state, I think they have about 18 local governments, and in each local government, they are supposed to have at least 2 primary healthcare facilities, which is supposed to have about 6 to 8 nurses and the likes. And if you calculate that, it's not up to what is expected. And so that's why you have issues around that. Oh, what's happening? It's kind of, okay. All right. Okay, for category 2, so the first thematic area as well, the human resource for health policy and strategic plan. This person also mentioned that they once had a plan, but currently they don't have this. Also, in terms of financing, yeah, our funding is mainly from the government. For instance, the state government now prioritizes the health sector as much as the education sector. So for this state, the government is quite intentional about funding the health sector or funding the primary healthcare services at the state level or at the subnational level, as we may call it. And for the information system, there's a state health workforce registry that we use in the state, and there have been multiple updates on the registry, but this has not been reflected in national workforce registry, which means that they are not connected to the human resource for health information system, because that comes from the national, and of course you get to filter for state. So for production and in-service training, we have several schools under the Ministry of Health. They are nursing schools and colleges of health technology and sciences. The nursing schools are often used to train the nurses, while the colleges of health technology and sciences are often used to train the community health workers. And so it's more, it gives room for segregation or trying to put them into different categories and making training easy. And so they are then integrated into the health system afterwards. So, but this is what the person said, but based on what we observed in the state, not all health workers are actually integrated in the health workforce. So in terms of midwife size and distribution, our staff distribution is currently skewed because we have many nurses and midwives in urban areas compared to rural areas. We want the government and partners to do something about it. You see, it's slightly contrary to your finding, which yours is more like there are people willing to work in the rural areas, but I would say more or less in Nigeria, many people don't always want to work in the rural communities because they feel like there are little to no amenities in those kind of settings. So it's always a problem. Now in the third state, or the third category. So for the leadership and governance, the participant emphasized that as it stands now, there's no HRH policy for the states for primary health care. We don't have that yet, but for the entire health sector, it is in the pipeline. So for their primary healthcare service particularly, they actually don't even have any policy in place. And in terms of financing, they wholly rely on the BHCPF funds that is being provided to them. So the government don't actually support, the state government particularly, don't actually provide an allocated funds to them for human resource for health particularly. For the information system, they also don't have the HRH information system. And so they stick to the nominal rule that comes in paper or in their manual ledgers. And in terms of production and in-service training, we have nursing schools and schools of health sciences. The schools of health sciences is quite similar to College of Science and Technologies. So basically they use this to train community health extension workers, but there are infrastructural challenges. So what this person actually also called out was that in their School of Health Sciences, or even in some of their nursing schools, they had infrastructural challenges, maybe like laboratories not being available, some equipment needed in those laboratories also not being available, and things like that. And so for midwife size and distribution, the participants called out that there's huge disparity across the local government areas. For instance, there are LGAs with adequate, and there are some without adequate health workers. So it's imbalanced, basically, according to the participants. I think I keep pressing. Okay, for the fourth category, the participants here mentioned that they actually had a plan. Then the plan, we did the study in early 2024, but the participants emphasized that the plan actually lapsed in 2023, and they are currently, at the time, they were working on finalizing a new one to then use that going forward. So for financing, there's no budget cut for human resource or like other program areas. So basically, this is also about the government not having specific funding for HRH in the state. And for the information system, they were able to have someone come up, support them in developing the HRH system in their state, but could not really use it. So that was a challenge for them. And I think by now they would have resolved that problem, because we had discussion on how they could manage it and where they could get technical support. For production and in-service training, so these participants highlighted that their goal was to have about 16,000 health workers. But currently they wanted to train 16,000 potential health workers, but currently they've only done 5,000. So I think this is also because within this particular state, the level of socioeconomic problem in the state makes it difficult for people to actually send their children to school, but rather send them to farm or trading. They tend to ignore academics than, trying to go into, they believe more in just trying to survive than focusing on trying to get their children educated. But I think currently things are changing in this state. The current government is trying to address that. Then in terms of the midwife size and distribution, the participant highlighted that to address our current workforce gap, we rely on volunteers, ad hoc midwives, because that is what the BHCPF funds can cover. So basically, the funding is slightly what is helping them, and they can only use ad hoc staff. And so this last category of state is the only one that seems to have every thematic area here covered, in terms of the policy, the financing, the information system, and production and size. And as a matter of fact, for production and in-service training, they actually intend to even go beyond the current health training institutions they use, but also to include other health training institutions or health institutions to train their nurses. So the conclusion is that the study highlights the significant Nigerian HRH quagmire across the study settings, unstructured system, and poor HRH planning across 4 out of the 5 selected states. While qualitative study cannot be used for generalization, of course, but it gives us an idea of what can be expected in each of the categories that we've actually identified. The study also gains stakeholders' insights on strategies to holistically assess the HRH situations and PHC facilities across the country. And based on our findings, we've actually recommended some valuable ideas for the government in each state, or things we have for the national government that can help support each state. So one of which is to provide accountability mechanism to improve the implementation of existing HRH policy. Another is to establish an electronic-based performance management system to track the quality of care, and also implement a 50% upward review of monthly salary, because one of the things that can be very discouraging in the health workforce system of Nigeria is the meager amounts of money they are being paid per month to then provide different services, which in many cases overburdens them. And I think it's also one of the things that drive absenteeism amongst health workforce. And also to deploy an electronic training platform for SBAs to aid easy access to contemporary obstetrics procedures. Thank you.
Merci beaucoup, Dr. Isiaka. Nous passons rapidement, comme le temps nous est compté, à la 4e et dernière présentation pour appeler Dr. Diwo. Donc, sa présentation porte sur l'impact de la coopération internationale pour la santé dans la réduction de la fuite des cerveaux médicaux en provenance d'Afrique. Les principaux canaux sont-ils importants?
Oh, okay. Okay, I see. Ok, merci beaucoup pour l'occasion que AFIA nous offre pour présenter nos travaux. Alors, donc, je vais faire ma présentation en français. Elle porte sur l'impact de la coopération en matière médicale, la coopération internationale en matière médicale dans la réduction de la fuite des cerveaux en Afrique. Et on s'interroge surtout sur les principaux canaux de transmission de cette coopération sont importants dans nos pays. Okay. Alors, il faut dire que depuis les années 90, la fuite des cerveaux dans le secteur de la santé en Afrique est devenue une préoccupation au niveau mondial. Pourquoi? Notamment parce que la région Afrique est la région où les problèmes de santé sont les plus urgents avec des défis énormes. Et si nous regardons un peu ce tableau 1 qui présente la distribution de la fuite des cerveaux qui touche ici les médecins, c'est-à-dire l'immigration des médecins et la densité médicale à travers les régions du monde, qu'est-ce qu'on constate? On constate tout de suite que la région d'Afrique subsaharienne notamment avait en 1995 le taux d'immigration des médecins la plus élevée comparativement aux autres régions. OK? Et si nous regardons également en 2004, le taux passe de 16% à 19%, largement au-dessus des autres régions. Et lorsqu'on regarde également la densité dans ces régions, on constate que l'Afrique, de façon contradictoire, là où le taux est élevé, on a la densité très faible. C'est tout à fait normal, si les gens migrent. OK? Et cette densité est passée de 0,15 pour 1000 habitants à 16, à 0,7 pour 1000 habitants. Regardez les cas entre 1995 et 2004. Donc, les progrès dans l'enrôlement des ressources humaines ont été vraiment minimes. Et pourtant, on se rend compte que, comme je l'ai dit tout à l'heure, c'est dans ces régions-là que les défis du système de santé sont énormes. Mais ce qui va nous intéresser le plus dans cette présentation, c'est que lorsqu'on interroge la littérature sur les causes, ce qu'on appelle les push factors, on se rend compte que le système de santé, l'inefficacité du système de santé, notamment incluant notamment les conditions de travail, ils sont sont parmi les déterminants les plus cités. OK? Mais en même temps, on se rend compte que la même littérature dit que si on a des systèmes de santé qui sont renforcés, alors ce renforcement peut réduire l'immigration. OK? Et cette littérature, elle fait la promotion, elle soutient notamment les politiques, les instruments internationaux mis en place, mises en œuvre au niveau international qui cherchent à renforcer le système de santé. OK? Et parmi ces instruments, il y a 3 qui nous intéressent ici, que nous allons appeler instruments de coopération internationale dans notre recherche. Et on a l'aide à la santé. Voilà, l'aide à la santé est devenue a suscité un intérêt croissant dans le cadre des UMD, et notamment les pays qui apportent l'aide ont pris l'engagement d'augmenter leurs apports, leurs contributions par rapport aux pays qui en ont besoin. Et le deuxième instrument ici, c'est la déclaration d'Abuja. Cette déclaration, c'est un engagement de nos chefs d'État en 2001 qui avaient décidé d'accorder plus d'attention aux dépenses de santé, au secteur de la santé. Et dans leur décision, dans leur engagement, ils prévoyaient attribuer au moins 15% des dépenses gouvernementales à la santé pour lutter contre certaines pandémies, le fardeau, etc. Et récemment, en 2010, l'OMS, et ça c'est notre 3e instrument qui nous intéresse, l'OMS a adopté le code de bonnes pratiques pour le recrutement international du personnel de santé. Ce code poursuit également les mêmes objectifs, c'est-à-dire qu'il faut réguler la migration des médecins dans le secteur de la santé, surtout. Et ce code établit des guides de recrutement dans les pays. Et ce code soutient également la coopération avec un soutien technique et financier aux pays en développement. Alors, si ces instruments-là sont implémentés de façon normale, de façon claire, il est évident que leur impact sur le système de santé pourrait réduire la fuite des cerveaux. Pourtant, ces instruments-là, la littérature a accordé peu d'intention à l'évaluation de ces instruments-là et aux canaux par lesquels ces instruments-là peuvent affecter ou bien réduire la fuite médicale dans nos systèmes de santé. Et donc, notre travail cherche donc s'intéresse donc aux canaux par lesquels, ce que nous appelons ici les 3 instruments, la coopération internationale en matière de santé peut réduire la fuite des cerveaux dans le secteur de la santé. Et notamment, on cherche à savoir par quel canal l'aide à la santé peut réduire la fuite des cerveaux. Le code de bonnes pratiques de l'OMS, adopté en 2010, a contribué à réduire la fuite des cerveaux. La déclaration d'Abuja de 2001, quel a été son rôle et par quel canal cette déclaration a permis de réduire la fuite des cerveaux en Afrique. Et bien évidemment, nous cherchons à savoir la synergie dans la mise en œuvre de ces instruments, notamment par un effet d'interaction. Comment est-ce que cela pourrait contribuer, ou bien cela a contribué déjà à réduire la fuite des cerveaux en Afrique. Alors, pour cela, nous avons documenté des données sur la migration. Parce que dans la littérature, on avait remarqué que les données étaient rares. Et donc, nous avons pris contact avec les Medical Council et les Nurse Council dans les pays de l'OCDE, où sont notamment la plupart des médecins et des infirmiers qui ont migré à partir de l'Afrique. Et ça, c'était notre première source. Nous avons aussi des données que nous avons consolidées. Et nous avons également, comme deuxième source, regardé la base de données de l'OCDE sur la migration de la force de travail dans le secteur de la santé. Troisième source que nous avons utilisée, c'est la base de données de Bagawa, Dogué et Moulan de 2011 et bien évidemment des rapports scientifiques et des articles scientifiques pour des données documentaires pour compléter la base de données. Avec cette collecte de données secondaires, nous avons créé une base de données sur les flux des migrants dans le secteur de la santé, notamment les médecins et les infirmiers, qui, pour les médecins, pour 53 pays d'Afrique, et pour les médecins, il s'agit des données couvrent 29 pays de l'OCDE, 29 pays, 28 de l'OCDE et l'Afrique du Sud. Et pour les infirmiers, on a pu collecté des données dans 21 pays de l'OCDE, hein, et la base de données est construite de 90 à 2020. Et ça, donc ça, cette base de données nous a permis d'avoir les données sur les migrations. Ce que nous avons appelé coopération internationale, nous avons collecté des variables à partir des bases suivantes. Pour l'aide à la santé, nous avons utilisé l'aide à la santé par tête, hein, dans le country reporting system database. On a pour le code de bonnes pratiques. Là, nous avons été confrontés à un problème réel parce qu'on a reçu de l'OMS, à partir des données de l'OMS, le lien en ligne qui renseigne les rapports des pays sur le suivi du code de bonnes pratiques. Et ce sont des questionnaires. Et dans ce questionnaire-là, dans ces questionnaires, tous les pays de l'OMS envoient des rapports sur le suivi du code à l'OMS. Et les questions évoluent. Les questionnaires ont largement changé. Le questionnaire de 2012 et celui de 2021 sont très différents. Notamment, il y a des questions qui ont été ajoutées. Et donc, notre objectif, c'était vraiment de construire un indicateur qui nous permet de retracer fidèlement et de façon pertinente la mise en œuvre du code dans les pays. Finalement, avec la difficulté qu'on a eue, on est obligé de retracer une seule variable dans ces questionnaires-là. Et à partir de cette variable-là, à partir de cette question, on a pu construire une variable indicatrice qui prend la valeur 1 pour le pays et l'année. Et pour le pays, voilà, lorsque le pays déclare avoir commencé l'application du code dans son système de santé, on met 1 à partir de cette année jusqu'en 2020 et 0 ailleurs pour ce pays. Et voilà, donc c'est ce que nous avons fait pour cette variable. Et pour ce qui concerne l'engagement d'Abuja, bon, on a pris l'aide publique à les dépenses de santé en pourcentage du PIB des gouvernements. OK? Et pour ce qu'on a voulu voir, ce qu'on a voulu considérer comme variable de transmission, nous avons pris un proxy pour les infrastructures de santé qui est le nombre de lits pour 1000 personnes. On a pris la densité médicale et du personnel infirmier que nous avons considéré comme l'enrôlement dans nos pays, dans nos systèmes de santé. Également, la prévalence du VIH-Sida qui est notamment citée dans la littérature. Et comme variable de contrôle, on a pris le PIB par tête et puis l'enrôlement dans le secondaire dans les pays. Alors, approche économétrique, oui, 2 modèles. Un modèle à effet fixe d'abord qui analyse l'effet de nos variables de coopération. OK, résultat. Wow. Alors, donc, on se rend compte qu'après tout ça, on se rend compte que l'aide à la santé a un effet direct et indirect sur l'immigration de médecins et des infirmiers. Et cet effet transite par le canal de l'appui aux infrastructures et à la lutte contre la prévalence du VIH, également pour l'aide à la déclaration d'Abuja. Mais surtout, le code de bonnes pratiques n'a pas d'effet, mais son effet est ressenti dans la variable d'interaction avec l'aide publique et les dépenses du gouvernement pour la santé. Alors, donc, qu'est-ce qu'on peut dire? On se rend effectivement compte qu'il faut accorder une importance à cette coopération. Il faut que ces instruments-là soient mis en œuvre dans nos systèmes de santé de façon concertée, de sorte à créer des synergies qui peuvent vraiment alléger les défis auxquels nos systèmes de santé sont confrontés. Et bien entendu, ce matin, dans le panel, on en a parlé. Si on touche véritablement les problèmes qui poussent, c'est vrai que ce sera compliqué pour certains, pour certains problèmes comme les salaires, parce que bon, les salaires n'ont pratiquement pas bougé dans la plupart des pays. Mais on est évident, on est sûr, il y a une évidence que si on touche vraiment de doigt ces défis-là, cela peut contribuer à réduire l'immigration de nos forces de travail, notamment dans le secteur de santé, et bien entendu améliorer nos résultats dans le système de santé. Je vous remercie.
Merci beaucoup pour les présentations. Nous vous demandons de les applaudir encore, les 4 présentateurs. Donc, nous sommes au regret de vous dire que nous avons un problème de temps. Il y a une session qui doit démarrer dans la même salle. Donc, c'est même passé, c'était depuis 11h30. Donc, nous allons juste faire un résumé. Et après, peut-être les questions, vous pourrez voir les auteurs. Voilà, au niveau de la plénière ou d'or. Donc, pour la première présentation, nous pouvons retenir que l'objectif était d'analyser la relation entre l'absentéisme des collègues et l'épuisement des professionnels de la santé en examinant le coût émotionnel, parce que l'absentéisme de certains personnels se répercute sur d'autres. D'autres maintenant seront surchargés. Maintenant, la méthode qui a été utilisée, c'est une évaluation rapide entreprise à Enugu, dans le sud-est du Nigeria. Donc, l'étude porte sur 54 pays. Les résultats montrent une surcharge de travail et un stress créant des problèmes de santé pour le professionnel remplaçant. Pour ce qui est des résultats également, nous pouvons dire qu'au moins la moitié des pays où les pénuries de personnel de santé sont les plus importants, ont simultanément un taux de chômage important. Donc là, c'est par rapport à la deuxième présentation. Il importe donc d'élargir l'espace budgétaire pour pouvoir améliorer la gouvernance du personnel et absorber le personnel excédent et réduire le chômage. Donc, pour la présentation de Dr Saïd, qui porte sur les soins de santé primaire, nous pouvons dire que, comme contexte, que les soins de santé primaire sont essentiels pour avoir un système de santé solide et résilient. Et l'objectif de son étude, c'était d'analyser les perspectives des parties prenantes dans les soins de santé primaire. Le contexte maintenant, pour le contexte, nous pouvons retenir que la mortalité infantile et maternelle reste élevée. Et il a utilisé une méthode de recherche qualitative avec les revenus de certains personnels. Il a également utilisé le cadrage d'action de l'OMS. Donc, avec 59 interviews avec les parties prenantes. Les résultats montrent un problème de financement au niveau des ressources humaines, plus particulièrement avec les sages-femmes, manque de plan stratégique, bien que le programme soit soutenu par le Canada. Les répondants, il a également noté que les répondants ont une expérience de travail. Les sages-femmes qui jouent un rôle important aussi dans le plan, une situation hétérogène, les collectivités locales ont également joué un rôle important avec ce qui a permis un recrutement de 600 agents de santé communautaire. Les écoles de formation sont intégrées aussi dans le système de santé. On a une distribution inégale et qui reste un défi. Pour la 4e présentation, c'était l'impact de la coopération internationale pour la santé dans la réduction de la fuite des cerveaux médicaux en provenance d'Afrique. Les principaux canaux de transmission sont-ils importants? Le contexte montre une importante revue de la littérature qui remonte de 1990. L'objectif était d'analyser les canaux de transmission de la coopération internationale et la méthode qui a été utilisée regroupe un ensemble de données de flux de fuite de cerveau pour les médecins et les infirmières de 53 pays, vers 29 et 21 pays de destination avec plusieurs questionnaires différents. Les résultats montrent que l'aide publique à la santé réduit directement et indirectement la fuite des cerveaux. L'instrument politique de l'engagement d'Abuja également réduit la fuite des cerveaux par les canaux des infrastructures de santé et la réduction de la prévalence du VIH-Sida. Le code de Léomin de l'Organisation mondiale de la santé ne réduit pas directement, mais joue un rôle dans les effets réducteurs de la fuite des cerveaux. Donc, nous vous remercions encore et nous vous demandons aussi de nous excuser pour ne pas avoir le temps de vous donner la parole pour les questions.